Thank you so much for coming today. It's really nice to see so many people. We're all separately, passionate about women's health, and hopefully that comes across today. And hopefully you guys all learn something you didn't know before, um, and find it interesting. That would be nice. Um, so if we make a start now, but just if you have any questions at any point during the presentation, if you can put it um in the comments, and then we can come back to it at the end for like a Q&A session once we finish presenting. But yeah, hopefully you guys enjoy.
Yeah, so if I get started with myself, can you guys all hear me okay? And can you all see me okay? Just double checking. Perfect, thank you. So I'm Kavya, and I'm a second year medical student at the University of St Andrews, all the way up in Scotland. And just to start off, I'm going to go on to a little bit about me, if that's okay. If you could move the slide along, Charlotte, that'd be grand. And so today I'm going to be talking a little bit about women's participation in research itself, and then also just a little bit about women's health in sport and some of the gaps in that, which stem a lot from the research. And the reason why I wanted to do this is because I'm very incredibly sporty. I play at the badminton team out for St Andrews. I'm medic netball captain, and I kind of just jump into sport as much as I possibly can. And in the future, ideally, I'd love to be a sports medic, kind of like a doctor for an Olympic team, travel. That's my amazing future if I can do that. So that's why I'm passionate and very interested about women's health and women in sport, especially. But yeah, I'll move on now to having a little chat about how women were left out of medical research. So next slide, please. Headache. So for this slide is pretty much what it says on the tin. So for ages, the male body has been seen as the norm in medical research. We have that 70-kilogram male figure, and that's what we use to kind of do all of our research pretty much for today's day and age. Women have been labelled too complex. This is because of our hormonal cycles, the potential of pregnancy, people being worried about fetuses. And so we've been using findings from those male-only studies to generalize for everyone. And medicine has been treating women's bodies as deviations from the standard rather than a standard in their own right, if that makes sense. So this one size fits men approach shaped diagnosis and treatment for all women in today's day and age. Next slide, thank you. And so the systematic exclusion of women stemmed from basically up until the 1990s. The FDA in 1977 issued guidelines explicitly excluding women of childbearing potential from early phase clinical trials, and that was citing due to risks to fetal health. And pre the 1990s trials, research consistently found that about 20% of participants in drug trials were women, and that came from the GAO report in 2001. And some of the conditions that affect women very much differently was heart disease. Despite being considered one of the number one killers of women, most cardiac research is focused on male symptoms like chest pain and ignoring signs that are more common in women, such as fatigue, jaw pain, and nausea. And that's come from the Lichtman et al. Circulation sex differences in the presentation and management of cardiovascular disease. And in terms of pain studies, a 2008 review has found out that 70% of pain studies used only male animals, even though chronic pain disorders are much more prevalent in women. And in terms of endometriosis and autoimmune disorders, conditions primarily affecting women were also often misclassified as psychosomatic or understood. So I don't know if any of you have heard of the term hysteria before, and they basically kind of thought that women were sort of making up in their heads and there wasn't really a biological purpose behind it. And that came from the Endometriosis Foundation. And the irony of all of this is that these complications should be precisely why women should have been studied, yet their exclusions have led to massive gaps in our data today. And if we move on to misdiagnosis and mistrust, this isn't just a data issue overall, it's a care issue. Women were misdiagnosed, dismissed, and left in pain because medicine didn't understand their bodies, and we don't truly understand our bodies today. Heart attacks in women present differently, but they're under-recognized. We are also more likely to experience atypical heart attack symptoms. And findings found that 60% of women under 55 didn't experience chest pain during heart attacks. And I think, at least for me, I've been taught that like one of the biggest symptoms for having a heart attack is just feeling pain in the chest, is something that you're very much taught at medical school. So that was a very interesting finding for me. And in terms of diagnostic bias, a large study found that women were a lot less likely to be correctly diagnosed with heart attacks in emergency department, and they're also less likely to receive life-saving interventions like angiography or aspirin therapy. In trials, obviously historically underrepresented, and and from the USA FDA drug trial snapshot summary in 2020, especially in cardiology, drugs show a consistent gender imbalance on trial participation itself. And you're gonna be hearing a lot more about chronic illnesses, especially stuff like endometriosis later on, which I'll leave the experts to do that. But women's pain overall is just less likely to be taken seriously by healthcare providers themselves. However, we've got some positives coming. In 1993, in America, there was a huge shift, and the NIH mandated inclusion of women in US-funded clinical trials, and that's seeing a lot more over in Europe as well. We have a lot of increased advocacy for sex-specific analysis and research. Loads of studies still fail to disaggregate data by gender. However, this was a huge turning point. It did come slightly alarmingly late, and even today, enforcement is patchy, and inclusion doesn't necessarily guarantee that meaningful representation. But in terms of the gaps that persist today, if I could get you to move on, Charlotte, please. Yeah. Sorry. The FDA drug trial snapshot, which I mentioned very briefly earlier, participation varies significantly by therapeutic area. So in cardiovascular trials, they often had a much lower female inclusion. Devices have been primarily tested on men. So these are like stents, pacemakers, and they've been historically tested with male predominant samples. Sex-specific devices performance is not often analyzed or reported. And women of color also often face compounded exclusion. And we have a lot of intersectional neglect where research often fails to disaggregate data by both sex and race, masking inequalities. And that came from the National Academy of Medicine in 2022. And medical education often lacks gender specific content. So a 2021 review found that the UK medical curricula, which is what all of you I'm sure are wanting to go into, rarely actually addressed how diseases manifest differently in women except in reproductive health. And that came from the BMJ in 2021. So that's a very brief overview of sort of the patches in research and how women are fit in. And now I'm going to move on to women's health in sport and just talk a little bit about that in a very brief overview. But to start off with female athletes, what is different between us being sporty as females and males just being sporty themselves? So we've got our menstrual cycle affecting energy levels. That's going to affect our energy risk and our performance overall. Hormonal contraceptives that can alter our metabolism and recovery. Lower testosterone does impact our muscle mass and recovery time. And there is this concept called RED-S, which is relative energy deficiency in sport. And that'll come up a lot in my later slides as well. But it's basically saying that female athletes are commonly underfueled and we have a lower energy availability. And it's not enough to fuel both our physical activity and our normal physiological processes like menstruation, bone maintenance, or immune function. Women's physiology isn't a limitation to us doing sport, it's just different. And I think that's quite an important thing to be thinking about. These differences require research based support and tailored care in order for women to also have the best support when they are athletes as well. And in terms of the risks, oh, sorry, I just lost my notes completely. Okay, and in terms of the risks, women's injuries are often blamed on poor form or hormones, yet the trust issue is in the research gap, not biological flaw. So, like, I've got some stats up there, but ACL injuries, women are 2 to 8 times more likely to tear their ACL than men. We've got a lot of under-researched areas, concussions, pelvic floor dysfunction, and breast injuries. RED-S, again, affects bone health, fertility, immunity, and mental health, and many studies of course, still focus on the male athletes. Red S can be intentional due to the pressure to stay lean. That's, I think, we can see a lot on social media. We have that extra pressure on women and not realizing how much fuel is actually needed. Female athletes are especially vulnerable, particularly in sports emphasizing leanness like gymnastics, distance running, dance, figure skating, where your image is very important to the sport as well for the aesthetic. But we are trying to break the barriers. We're seeing the shift, but it's athlete driven, not institution led, which is a bit unfortunate. But visibility is power, and representation does change research priorities. So we're looking for more female focused research, like menstrual cycle tracking in elite sports. Nike, Adidas, and other developing um, and other companies have been developing female specific gear and sports bras. Women's teams are gaining access to strength and conditioning coaches trained in female physiology. And we're seeing a lot more advocacy from athletes like Simone Biles, Serena Williams, and Jessica Ennis on equity and visibility, which is really changing the game today. But overall, supporting women in sport means more than equal access. It means tailored care, real data, and cultural change. And if I get you to change this slide over, please. We just need to invest in research that reflects women's bodies, normalizes menstrual tracking, pelvic health, and all of those long-term outcomes. We need to train our coaches and medics in sex-specific needs and elevate our female voices in sports leadership and science. That concludes my section of the webinar today on research and with a specific focus in sport. And I'm going to hand over to Harriet, I believe.
Okay, yeah. Hi guys. Can everyone hear me okay before I start talking? Okay, good. Change the slide, please. I'm going to be talking today about endometriosis. So just a tiny bit about me first. I'm a current third year medical student and I have a big interest in obstetrics and gynecology. I actually haven't had my placement yet on obs and gynae, but my 3 rotations this year have really exposed me to the women's health field. It's an area that I feel really passionate about, and hopefully that comes across today. And I guess why I wanted to do this webinar in the first place was because you guys are the next generation of medics, hopefully. And I really do believe that we can improve women's health by informing people so people are informed and you guys can go on and be great doctors in this area. So change the slide, please. Okay, so some statistics on endometriosis. Endometriosis affects 10% of all women and girls globally, which is 190 million people. But it is worth bearing in mind that obviously those statistics are people with a diagnosis. There are probably many, many more people still waiting or with suspected endometriosis. And the time for diagnosis in the UK is 8 years, which don't know about you guys, but 8 years really shocked me when I was doing my research on this. That's a very long time to be waiting for a diagnosis for a progressive disease. And it's not even going in the right direction, unfortunately. It's going the other way. It's moving since the pandemic and actually getting taking longer for diagnosis post-pandemic. And the National Institute of Health in the US only allocated 0.038% of its budget to endometriosis in 2022, which roughly equates to about $2 per patient in the US. And a global study by the University of Oxford found a shared genetic basis for endometriosis with other chronic pain types, including chronic back pain. So what this means is that hopefully in the future, with a bit more money, a bit more resources, we can find treatments that can actually link all these kind of chronic pain conditions that we see that often come together. Change the slide, please. Yeah. What is endometriosis? So I don't think this is actually very well understood, I'd say, in the general public, but it is essentially a disease where the tissue, like the lining of the uterus, grows outside of the uterus. And it can be found in areas around the womb, such as the ovaries and fallopian tubes, but it can also be found in areas like the bowel and the bladder. And the whole kind of reason why it causes symptoms is because this tissue shouldn't be there. Endometrial tissue, it acts like the lining of the uterus does. So you build up the lining, then it gets shed. And the problem is it gets shed in the uterus, that's fine, and we can clear it. It gets shed outside the uterus. There are problems because if it's in a location where it can't leave the body, that's when we get all this inflammation and nasty stuff happening. And that's why you get all these horrible symptoms that come with endometriosis. Change slide. Yeah, Charlotte's on it. So this is a bit of a horrible looking diagram. But I'm not going to go into it in too much detail because I think, quite frankly, I wouldn't know all the ins and outs of it. But at the top, you have your endometrial fragments from retrograde menstruation. And then we have healthy women on the left and endometriosis patients on the right. So in healthy women, these fragments are cleared by apoptosis, which you'll learn all about in medical school, but it's basically breaking things down by the immune system. And that's all good, and it's mediated by TNF alpha. The problem is when you get an endometriosis patient that there are a number of different pathways which I tried to understand, but it was very complex, that essentially mean that it can escape this, which means that there is evasion of immunosurveillance and things like proliferation are allowed to happen, which then means that endometriosis can progress, essentially. It's complex. I'm trying to break it down, but it is quite a complex process. In essence, that tissue shouldn't be there and it causes inflammation, which causes the symptoms. So the pathology is all good and well, but a patient's never going to come and present to you speaking like that. They're going to come and present to you speaking like this, which is what I'm going to talk to you today, because one day you might see, I mean, you probably will see a patient who presents like this. So early exposure is a good thing in my opinion. So how may a patient present to you in the future? Essentially, there are symptoms that people get during their period, and these include things like severe and disabling period pain, heavy periods, which the NHS says is it's hard to define, but basically, if you're changing your tampon or period pad every 1 to 2 hours to prevent, the blood going completely through your clothes, kind of thing, and pain on going to the toilet. Patients might not necessarily present speaking like this. They're more likely to come to see you and say, I've got a really nasty period. When I'm on my period, it really hurts. I can't leave the house because I'm so heavy. I just have awful cramps. It's really debilitating. That's how somebody might present. There are also symptoms at other points during the menstrual cycle. So, for example, pelvic pain, which is your lower stomach and back region, pain during or after sex, things like fatigue, diarrhea or constipation, bloating, nausea, and it may also present to you as an individual having difficulty trying for a baby or with low mood and anxiety. So I think, to be honest, the really important thing here is to listen to the patient and let them explain to you what's going on in their own language and try and piece it together yourself. And I think sometimes it's not necessarily clear cut. Sometimes patients will describe things and you'll think, not entirely sure what you're trying to say, but just try and keep this in mind and hopefully view the patient as a whole picture rather than just a few symptoms here and there. Okay, so I'm not going to talk too much about this because I think Charlotte's going to do a bit about this later. But in terms of investigating and diagnosing endometriosis, there is examination using a speculum, which may reveal endometrial tissue that's visible in the vagina. On examination, the vagina and cervix may be tender. Pelvic ultrasound can reveal endometriomas and chocolate cysts. And the gold standard for diagnosis is laparoscopic surgery through biopsy. So, the big question is what's the problem? Because you might be sat here thinking, hold on, I've taken you through the symptoms, I've taken you through the pathology, which just took a quick Google. Like, these are all things you can find online. Why is it 8 years? Like, why is it taking 8 years to diagnose these women? So there's clearly a problem somewhere, but where's the problem? Okay, so this took me about a minute to Google. I literally just put into Google endometriosis BBC, and this is what came up. Not overly positive things. Women with endometriosis earn less, research shows. Colleagues thought I was faking endometriosis pain. It was soul destroying waiting for a diagnosis. all these like women upon women talking about their struggles and how things have got to change, essentially. So yeah, honestly, I was thinking the same thing as you guys probably are now. But I had a look, and there was research done by the University of York which highlighted some of the reasons for a delay in diagnosis. And this included things like existing stigmas, reliance on women's self-reporting, and poor medical reporting. So, what that all means is existing stigmas. This might present to you as a gal who's really embarrassed because it's about her periods. Sometimes I think we've made progress in society, but I still say sometimes it's a bit of a taboo subject. You know, there's still a bit of shame around talking about periods, I think, sadly. So, you know, people may not seek help because they're embarrassed and they don't want to go to the GP and talk about um their periods and, you know, really intimate details about themselves. The reliance on women's self-reporting is that some people, if you're not educated on what's not normal with a period versus what's normal, you might not even go and seek help. So, you know, you might think that the pain that you go through on your period is normal. You know, like everyone gets pain, there's nothing wrong with me. And if people aren't then going to a GP or going to seek help, then they can't get diagnosed or it takes time. And then poor medical reporting is really interesting. According to this research, apparently, medical professionals aren't very good at reporting endometriosis symptoms and um, making kind of note of the symptoms. Apparently, it's quite poor on average and very disjointed between different branches of healthcare. People report differently, and the systems are different, and symptoms don't get transferred. It's all a mess from what I was reading, which is a real shame and hopefully something that we can work on. And then, of course, there's the treatment of women in healthcare. It's the classic kind of too many stories of a female going to the GP and the GP turning around and saying, oh, you know, it's probably just anxiety. It's just a normal period, like it's just a bit of period pain. Um, just take some paracetamol. Have you taken ibuprofen? That kind of thing. And when women are met by dismissal and someone not necessarily checking in that way, I think it puts people off going, or they hear stories about friends that were dismissed and they think, oh, nah, I won't bother going to the GP. So I think that's really important. And then just scientifically, endometriosis is similar to a number of other conditions. So it can present like adenomyosis, fibroids, pelvic inflammatory disease, and IBS. So that can complicate things a bit. So Ayla is a lovely girl who I met online. She has endometriosis, and this is her Instagram on the left, um, endosis. And she was meant to be here today, but unfortunately, she's just had quite major surgery, bless her, so couldn't make it today. But I asked her to send me what she would want to tell you guys in person about her experience and what she would want future doctors, how you should treat a patient like her in the future. So, what I'm going to do is just read out what she sent me, if that's okay. So, as someone who has been living with endometriosis and adenomyosis since 11 to then being diagnosed at 15, I think the most important lesson that healthcare professionals should know is that it's not just an adult's disease. A patient of any age knows their body the best. It took constant battles against gynecologists, A&E consultants, and doctors, as I was too young and my tests were normal. Yet I was diagnosed with severe stage 4 endo and adenomyosis at age 15, following on to a chemical menopause at 16, and then more complex surgery at 17. Patients will be so reluctant to come into A&E and the doctors about their concerns, as 9 out of 10 times they are gaslit and made to believe that their symptoms are normal and there's nothing wrong with them. The best thing that you can offer is compassion, understanding, and a multidisciplinary care approach. If you're not too sure, please find another medical professional that can help, such as an endometriosis specialist, a senior registrar with every encounter, scan, and test result, as it can take an experienced eye to look for and to get a second opinion or a diagnosis or a different treatment plan that can be made. So that's what Ayla wants all of you guys to know, and hopefully you'll remember that in the future. think, yeah, that's the end of my bit, isn't it?
And that was a really great lead into what I've got to talk about. So Harriet just mentioned about Ayla sharing her testimony. So my section of this presentation is talking about my experience with endometriosis, and focusing in on diagnosis and treatment. So just a bit about me. First of all, I'm not a medic. I'm actually a dental student. I'm at the University of Leeds. I've just finished most of first year now. So despite not being a medic, I've come to this sort of webinar because, first of all, I'm passionate about equitable access to healthcare across professions. You know, we have issues with access to healthcare in dentistry, but it's a widespread issue, so it's still relevant to me to be involved in things like this. And the main reason why I'm here today is because I have endometriosis, I have a diagnosis, and I've been experiencing it since I was 13, and I was diagnosed this year. So because of this, Harriet has allowed me to sort of join in and share my experiences with you and sort of talk about how diagnosis and treatment works. So I'm going to start off by talking about my personal experience of endometriosis. So the first time that I experienced the symptoms of endometriosis, I didn't actually realize that that was what was happening. I just woke up one day, which happened to be my 13th birthday. I just went about my day as normal and I fainted. Well, I didn't even actually faint. I lost my vision, was still conscious, which is a really terrifying experience because I couldn't see. I felt very disorientated. And once I regained my vision, I then proceeded to vomit. And this doesn't actually align with what a lot of people would consider as period related. So when we think about bad periods, we might think primarily about pain, but what you will learn through learning about endometriosis, and also from what Harriet's already said, it doesn't just present as pelvic pain. There are so many different aspects to conditions like endometriosis. So what made me realize that this was a long-term condition and not just a one-off was that it continued to happen. So I'd experience my period, I would have excruciating pain, and many times this would come with the loss of vision, the vomiting. So obviously this was quite scary, especially as a young teenage girl. So of course, the expected thing to do is go and visit the GP and see what's happening. So I went to my GP, and my GP had a special interest in women's health. So that felt quite encouraging to talk to somebody who, you know, supposedly is an expert in this area. However, I really felt that she was quite apathetic to what I was going through. So in summary, what she said was that it was unfortunate that I was experiencing it, but it's part of the process. You know, women can have children and they experience periods as part of, you know, the preparation for having children. And it's just, you know, one of the negatives of what is, in her opinion, very beneficial cycle to a woman. I was told that, you know, young girls, their periods are more painful at the beginning. It will settle down, not to sort of worry about it. And initially, you know, it was just recommended, you know, take some paracetamol, hot water bottle, those kinds of things. However, over the years, it transpired that this wasn't going to be enough. So I was recommended lots of different medications, none of which resolved the problem that I had. However, it was never considered that there might be something more to this than just a bad period. So I wasn't informed about conditions like endometriosis. That was something that I found out just from, you know, Googling what was going on. And whilst I was at home, so because I'm a university student, I've transferred my care now to where I'm at university in Leeds. However, with my GP at home, a resolution was never sought. It was just kind of, when you come back, you know, try something else. So it was very much accepted as if it was normal, and I was told that it would settle down. However, since I'm here today, we can probably all understand that that didn't happen. So there were a lot of mistakes made in my care, and this was frustrating because when you have a condition that involves this amount of pain, it can have a huge impact on your life. So for me, it was, you know, affecting my attendance at my sixth form. because if that happened in the morning and I'm, losing my vision and vomiting, it's very hard to just go about your day as if everything happens. When I started university, one of the treatments that I've been recommended that caused me to actually bleed pretty much consistently for about 3 months. And this really impacted my attendance at university in the first few months of term because I had this consistent bleeding from the treatment that I'd been suggested. And because of, it turned out it was endometriosis, I was having this almost constant excruciating pain. So I found it very difficult to attend university. So obviously my condition was having a huge impact on my life. So before I received the diagnosis, there were a few different things that were considered. So my previous GP had mentioned ovulation pain. I think later on I had suggested it might be endometriosis, but when I did suggest that, I was told the only way to confirm that you have that is through surgery, and we don't really want to put you through a surgery if we don't need to. So it was kind of never progressed on from there. I also went to hospital with a suspected appendicitis. And one of the positives of this was that I was receiving an ultrasound. I found out that I had a cyst, which didn't explain the pain, but it was a suggestion of what could have caused the pain. In terms of suggested treatments, it really varied. So over the years, I've tried, multiple analgesics, so painkillers, paracetamol, ibuprofen, lysine. So I've tried some NSAIDs, if anyone knows what an NSAID is. There are a slightly different type of analgesic, things like naproxen. There are medications like painkillers with codeine that are a bit stronger, which a lot of people with endometriosis do end up using sort of stronger painkillers, which is risky because strong painkillers can be addictive. And if you have a patient who's got undiagnosed endometriosis and they're having to rely on these strong painkillers, that can be quite risky for the patient because there is a risk of developing a dependence. I also tried some hormonal treatments, but hormonal treatments carry a risk of effects on other aspects of your body or your mental health that are controlled by your hormones. So this was not really working for me because the hormones are affecting my mood. I mentioned earlier that one of the treatments caused me to bleed a lot, which was obviously not ideal given that I had this endometriosis that was causing pain as I bled. There's another option for sort of painful periods. If anyone's heard of a TENS machine, it's a machine that you sort of put on your lower stomach and it delivers electric shocks to relieve the pain. So I'd really tried lots and lots of different things and I was still suffering and I decided that I was fed up. So I went to a new GP in Leeds where I'm at university and I said to them, this is all the things that have been happening in my life. I think I have endometriosis, and this was the point where somebody finally listened. And I had been listened to before, but it hadn't really benefited me. In this case, I was listened to and then action was taken. So my doctor wrote a referral for me to have further investigations of what was happening. So in terms of a referral for endometriosis, referrals are different for different integrated care boards. So these are sort of groups of different services in an area. So for example, Leeds has its own integrated care board. So if you have a referral, you can ask to be referred to a different place. For example, if I lived at home in Manchester, I could ask to be referred to Manchester. However, I chose to stay within Leeds. I'm going to share a bit of an overview of what my referral looks like. So the point of a referral is for the primary care provider to summarize what the patient is experiencing and then pass it on to a specialist so they can give the more specific treatment that they're qualified to give. Because if you think about a GP, their role is to identify problems from a wide variety of patients and a wide variety of conditions, whereas in this case, a referral to gynecology, they have a lot broader and deeper knowledge of these issues. So you're referred to a service, and then they will look at your referral and then decide what's best to do. So In an endometriosis referral, there will be a list of the different symptoms that you can experience, because it's not a specific referral for endometriosis, it's a referral to the gynecology service. So it has symptoms, sort of gynecological symptoms that might indicate you need further support. So not all of them will be specific to endometriosis. And there is clinical advice alongside it for the referring clinician, which is helpful because not all GPs will know the ins and outs of these conditions. It also suggests other potential causes to rule out, which is good because a referral can take a long time to come to fruition for the patient. So if it actually is a different condition and it can be ruled out, it's best to do that beforehand. There's also important information on a referral for what is an indicator that a patient should be put on a 2-week cancer referral pathway. Because obviously, if it's a referral to a gynecology service, there's potential for cervical and vulval cancers. So it's very clearly written in the referral. I'm pretty sure it's written in red. You know, if the patient has these symptoms, don't refer just normally, refer to the 2-week cancer pathway. So there's lots of information on there, and there's also a section for additional information, which is for the GP to write specifically about the patient. You know, they can add how long they've experienced the symptoms, how it's affecting their life, what they've already tried, and if they have a suspected diagnosis, so in my case it was endometriosis, they can add that there. So GPs might want to try other things before they refer to the specialist services, so I'm going to talk a little bit more about that later. In terms of how long it can take until you get an appointment, under the NHS Constitution, if your GP refers you for a non-urgent condition, you have the right to start your treatment led by a consultant within 18 weeks, unless you want to wait longer or unless it's clinically right for you to wait longer. However, this is an ideal that is not always met, which I will mention as well later. However, these goals that we have are not always met, which is can again be quite frustrating for people who are waiting for these sort of elective surgeries or treatments. Okay, so I'm just going to show you this, which is an example of what the referral looks like. So I kind of recreated it here. So we have the presenting symptoms. So this is coming under the sort of subtopic of abnormal menstrual bleeding. So this is heavy menstrual bleeding with no other abnormal bleeding. Then it's got a checkbox here for the referring clinician to select that this is true for this patient. And then over here on the right is the clinical advice. So this is for the advice for the referring clinician for things to consider. So if the patient has heavy menstrual bleeding, they want them to exclude pregnancy, because that's something that if it is the case and it is the cause, it's helpful for the patient to know now rather than waiting for a referral. They can examine the abdomen for check for a fibroid uterus. There's some suggestions of things that they could prescribe to try and resolve the issue. So there's tranexamic acid for heavy bleeding. So this is something that I actually was prescribed, despite the fact that I never reported heavy bleeding. This is another area where I felt that I wasn't listened to, perhaps by my first clinician, being prescribed a medication for a symptom that I didn't have. There's also a suggestion for medroxyprogesterone for irregular bleeding, and then it's got a warning for the patient if that is given. There's a suggestion to monitor the patient over the 3 months before referring. So this is a bit of a tricky one, because if the patient is reporting painful periods for the first time, then this kind of makes sense. But if it's somebody who's come to the clinician after months or years of this issue, being told to wait another 3 months could be quite frustrating. So that's something to consider if you were thinking about your practice in the future. It's something that you need to consider each patient individually. There is a point about requesting transvaginal ultrasound. I'm going to mention those a bit later. And there's also a point about some nice guidance, and there's a link there as well, which would be quite helpful for the referring clinician. Okay, so in terms of investigating endometriosis, there are 3 ways that that it would be investigated. So for ultrasounds, this is now recommended by NICE that the GP should offer a transvaginal ultrasound to all patients with suspected endometriosis. So this is, you can have, so if you think about ultrasounds for pregnant women, that's one kind of ultrasound. There's also the transvaginal ultrasound, which allows you to see the ovaries, the uterus. This can be a really helpful method of investigation. However, not all endometriosis will show up on an ultrasound. So a patient could be referred for this ultrasound, and it could look as if they have nothing present, which it can be frustrating for the patient because it feels quite invalidating. It also doesn't help towards determining whether there is an endometriosis or not, because if nothing shows in the ultrasound, but they have the relevant symptoms, then they will still be given a further investigation. They won't assume, oh, there's no endometriosis on this ultrasound. It might not be that. The second one is an MRI. This is something that I had when I received my referral. So an MRI is recommended for investigating deep endometriosis. So we mentioned before that there is endometrial tissue in the uterus, but we also know that it can spread. So for endometriosis, maybe around the bowels, that would be visible on an MRI. However, the guidance does include that the scan should only be reviewed by a healthcare professional with a specialist expertise in gynecological imaging, because it's quite difficult to interpret it, and it's not something that's really commonly used by other professionals. If endometriosis still doesn't show on an MRI, that's still not the end of the investigation. If a patient has the symptoms and it's not shown up on an ultrasound, it's not shown up on an MRI, then they will have an investigative laparoscopy. So this is a minimally invasive surgical procedure. So they use sort of the robot technology to look inside. And this is suggested as an investigative procedure if the endometriosis doesn't show up on the ultrasound or the MRI, but it's highly suspected. So this isn't the first investigative procedure by any means, but it is sort of lauded as the ideal. I think Harriet mentioned it earlier. However, they won't go to it first because surgery is quite an extreme jump from no intervention to surgery. Okay, so for treating diagnosed endometriosis, there are a few different options. So the first one is surgery. So again, laparoscopic surgery, which is to remove the endometrial tissue from the uterus or wherever else it is. So you would have a scan before that so they can ascertain where it is, and then they would remove it. If they find more while they're doing the surgery, they'll remove that as well. Then after you've had the surgery, they'll recommend a hormone treatment to maintain the results, because unfortunately, a surgery for endometriosis doesn't guarantee you'll be pain-free forever. It can regrow. So because of that, if a patient also has adenomyosis or heavy bleeding, or it's drastically, really, really affecting their life, there is also the option for a hysterectomy, which is the complete removal of the uterus. So obviously that is a big step for somebody to take to treat their endometriosis. So this is not normally considered as the first option. There's a big focus when treating endometriosis on trying to maintain fertility for patients that's relevant for. So a hysterectomy probably wouldn't be the first choice, but if somebody doesn't want to have children, it is an option for them. Aside from surgery, there's these sort of pharmacological options. So there's analgesics. So as I mentioned before, these are painkillers, and it's recommended to try a 3-month trial of analgesics before referral to further services. Neuromodulators are usually used for nerve pain. So these are things like amitriptyline, but that's less common in treating it. There's often a focus on mefenamic acid, which can reduce period pain. There are other treatments, so there's COX-2 inhibitors, which is something that isn't actually licensed or allowed on the NHS in my area, but it's something that if maybe a patient lived in another area, they'd be able to have that treatment. And finally, there are hormonal treatments. So some of the specific ones that there are is the Dienogest, which is a 2 milligram tablet that you take every day. There's also an injection, a hormone injection, it's called triptorelin, which you'd also take with a dose of HRT, which makes it which is a consideration for a young person trying to make that choice, whether you would want to be taking HRT. There's also your sorts of more common contraceptives that can be used for treating this condition. So things like the combined pill, and this can be used to manage the symptoms. Interestingly, so I was reading the NICE guidelines for diagnosing and treating endometriosis. There is a reference to an initial pharmacological management, but there isn't a lot of focus on other pharmacological treatments. The big focus is on surgery. If somebody didn't want surgery for any reason, I think it would be helpful for patients if there was more guidance for general practitioners or more research into other treatments. We have heard a lot in the news recently about treatments becoming available, but there's still not widespread knowledge. Okay. So what happens next? So for me personally, what happens next for me is surgery. So I'm on a wait list for surgery. Through the production of this talk, I actually, tried to have a check-in on my progress with my surgery. I found out that I've been waiting for 28 weeks and I have another 21 weeks to wait. So by the end of the time, I'll have waited about a year. So this really shows that the 18-week window that I mentioned earlier doesn't always happen in practice, which can be quite frustrating. Something that I think is important to consider is the difficulty of moving between services. So I had my diagnosis with one service, but that service didn't do surgery, so I had to be referred somewhere else for surgery. So now I'm kind of between services with nobody sort of having responsibility for my care. And this is tricky because, there's always possibility for admin issues moving between services. And it also means that in the meantime, I don't have anyone to, consult about my care for my endometriosis. I've had to go back to my GP and say, I've gone and got this diagnosis, I'm on the waiting list for surgery. But in the meantime, what can I do? And that's a really difficult situation for any patient because you have a diagnosis, but, it's not much help to you if you're still experiencing the symptoms because you haven't got any treatment right now when you're waiting for a surgery. So this was a bit frustrating for me because there are so many different treatments that I've tried and then none of them have been successful. I got my hopes up because it was mentioned about these COX-2 inhibitors, but again, they're not allowed to be prescribed in Leeds unless you have liver failure or you're on palliative care, which I'm not, fortunately. So, the treatment options are limited, which is difficult. So that's a little bit frustrating, but for all patients, who've had a diagnosis doesn't mean your problem is solved. All it means is that you have a label, which is really helpful because then you can seek care and treatment that's specific to the label diagnosis that you've received. But unfortunately, it's not sort of like waving a magic wand and everything will be fixed. So my sort of parting words on this is to talk about how this has affected me. So Ayla spoke about how her endometriosis has affected her life, and I think I kind of just want to add to that. So endometriosis has really affected my life, and it's not just because I'm experiencing pain. It also has impacted my mental health. So, I'm sure you can imagine if you're in pain most of the time, you don't want to leave the house. You don't want to go out the house and risk, pain coming on and not being in the best situation to deal with it. not being able to relieve the pain as much as you could. A lot of people, when they're suffering with endometriosis, they want to, curl up in bed, which you can't do if you're outside the house. So it can be quite a limiting illness. It also affects social interactions, which you might not consider. But again, if you're struggling with pain and you're not leaving the house, you're going to be limited socially. So in my experience, I mentioned that the first 3 months of my degree, I was really, really struggling with pain. So that's affected my ability to make friends, because everyone else is enjoying freshers and meeting new people, and I'm experiencing pain from my endometriosis at home. And it also makes it difficult to sustain existing relationships, because if your main focus in your life is your pain and managing your pain, it's really hard to also be able to prioritize, keeping in touch with people. And that can be really difficult. Endometriosis and conditions like it can dominate your life, which is difficult at any age. But I just think it's especially difficult as a young person, especially as a young woman, when you already have so many other things to deal with, especially when you're first experiencing it, because it can be so surprising. You're not expecting, your life to be affected so much by a period. So it kind of links to what Ayla said, but throughout my journey, I have often felt ignored and invalidated. I think it was Kavya who mentioned earlier that as women, we're not always listened to. And I think as a young woman or as a teenage girl, it's been difficult to feel that I've been listened to and been taken seriously by professionals because of this sort of stigma about periods and things like that. So I feel that, chronic and long-term health conditions are often accepted by professionals rather than actively investigated and treated, which can be really difficult. So it seems like a bit of a miserable topic, and it's a bit frustrating that I can't end this on a positive note and say, it's all fine in the end, because as, my colleagues mentioned, this is an ongoing process. We're hoping research will increase, but at this point in time, there's still an imbalance in how, healthcare is delivered. But unfortunately, even though there hasn't been, a happy ending to my endometriosis journey yet, I'm really hoping that I've helped you guys have an understanding of what it's like to live with endometriosis beyond just understanding the process and the statistics. And I'm really hoping that you've learned about treatment and diagnosis and that you've benefited from that. So thank you very much for listening to my experience. And I think we're going to briefly talk about PCOS. So I'll pass back over to Harriet.
Amazing. I just wanted to say I wasn't here for the whole thing, but I heard bits of it. I was joining on my phone and I've got back now. From what I've heard, incredibly brave, and thank you so, so much for sharing your experience, kind of lived experience of endometriosis. And if everyone in the chat, you put kind of a huge thank you to Charlotte for kind of sharing her own experience, being so brave in front of all of you guys. So very well done. And I know, as you said, it's a slightly negative note that we're ending on. But what I would emphasize is, well, it's not been great, but these guys are the future. And so we've told them all about what they need to do different, how they need to make sure their patients are heard, how they need to make sure they don't kind of neglect such conditions, they don't have any kind of intrinsic biases. It's such an important topic, and these guys literally are the future of medicine. So hopefully this has given them a really important insight so that we can make a very genuine difference. So thank you so much to all of you guys for presenting, especially to Charlotte. And if I let you guys finish off with PCOS, I didn't realize this wasn't the end. So let's let you guys finish with PCOS as well.
Sorry, yeah, it was a bit of a last minute addition because obviously there's such a widespread amount of conditions that can fall under women's health, but I did think this one was one that's particularly misunderstood. So even just one slide just to explain it for you guys. So PCOS, PCOS is polycystic ovary syndrome even. It's a common hormonal disorder that particularly affects women during their reproductive years. The features include things like irregular periods and symptoms from excessive androgens, which can look like hirsutism, which is male pattern growth of hair on females. The cause is not fully known, but it has been linked to insulin resistance, inflammation, and genetic predisposition. And the treatment options include things like lifestyle changes. So, for example, if applicable, losing weight, exercising. There are birth control options, metformin, which would increase the sensitivity to insulin, anti-androgens such as things spironolactone, and fertility treatments are all ways that you can treat PCOS. The I think what was really important to highlight was the less spoken about side of PCOS, which is the fact that women that suffer from this, they have 4 times the depression kind of rate of depression, because if you're thinking about things like male pattern hair on a woman, that can be something that people feel quite embarrassed about, or they just feel very self-conscious. And I think this isn't necessarily recognized enough. And then also, I think there was a movement to actually change the name, because a lot of sufferers felt that it was only focusing on the ovarian cyst part of it, rather than actually the fact that it's a multifaceted disease that incorporates lots of different things, such as that, like hirsutism and period disruption and that kind of thing. So I know that's a whistle-stop tour. It's actually not something I know very much about, because it's not very emphasized as far as I'm aware in medical school either. But that's the brief overview of PCOS. But I would recommend that if you're interested to actually go and read up about it a bit more, because that is very, very brief and there is a lot more detail there as well. But that's my very short bit on PCOS. The one takeaway I'd say is that it's more than just ovarian cysts. It's multifaceted. There are different things going on there. But yeah, that's that bit done. Yeah, sorry. So if anyone's got any questions, I think we've been kind of answering them as we've been going along. But if anyone has any more specific ones that they're thinking about, please just pop it in the messages and we'll try and answer them.
I'll scroll up and see if we've missed any as well. Sorry, Harriet.
No, it's okay. I was just going to say, like,
reply via messages, but just in case we missed anyone's,
I was just going to say, it's like a parting message, kind of what Ojas was saying. But you guys are going to be the future of medicine, and I think even by coming to this talk, you've shown that you're interested in this area, and hopefully you've learned some things today. And hopefully when you see patients in the future that are female, it's just important that you listen to them, like let them explain how they're feeling. Don't put kind of stigma or bias, or try to make them feel like you've listened to them, I think is the biggest thing that I can give you guys. I think, yeah, putting the patient first and letting them explain is the biggest thing you can do to make someone feel heard and listened to. And thank you, Charlotte, for sharing your story, and thank you, Kavia, for your bit as well.
So I've got a couple questions from the chat. Some of them are to do with this, some of them